Good afternoon, everyone, and welcome to this webinar organized by Eurotest and European Testing Week as part of the Spring Testing Week, which takes place this week. Testing Week is a campaign that aims to increase awareness of the benefits of earlier diagnosis of HIV, hepatitis, and STIs, and increase access to testing in both community and healthcare settings. So the theme for the testing week in 2024 focuses on the important role of healthcare providers in ensuring adequate testing offers in healthcare settings. So the European Centre for Disease Prevention and Control and European AIDS Clinical Society have just carried out a survey to measure HIV-related stigma and discrimination in healthcare settings, which is the theme of this webinar. At the webinar, we are very happy to welcome Timo Nori from ECDC, who will present the findings of the survey, and Esteban Martinez from EAX, who will give his reflections on the results. After that, there will be some time for discussion and questions from the audience, and we ask you to use the Q&A section to post questions. And you are able to do this anonymously, and we will read aloud the questions and hope to have some discussion with the panelists. Also, I have to mention that the webinar will be recorded and will, after words, be posted on the Testing Week's YouTube channel, and the link will be posted on the website and social media pages. So, first, over to our first speaker, Timo Nori from ECDC. Thank you for joining, Timo, and over to you for the first presentation of the results.
Thank you so much, Dorte. Do you hear me well?
Yes.
Good, excellent. So thank you so much for inviting me to speak on this topic of HIV stigma in the healthcare setting. So what I'm presenting here today is on behalf of EAX and ECDC, and these are preliminary results. They're not published yet, but we hope to be publishing them very soon. So the starting point for all our work is the Sustainable Development Goals, where goal 3.3 is where we talk about ending AIDS by 2030. UNAIDS is the global body that has defined what it means to end AIDS. They've got lots of targets and goals, as you know, and one of them, which I've circled here in red, it relates to stigma. So where it says less than 10% should experience stigma and discrimination. I'll just say a few words on that in a second, but first I just wanted to show you the latest data we have on the estimated number of people living with HIV in the wider WHO European region. So have by the end of 2022 is that 2.3 million people were living with HIV in the wider WHO European region. A third of those lived in the West, the countries in green here, 2% in the center, the countries in blue, and 62% of all people living with HIV are in the eastern parts of the region. So that's where the true burden of HIV is. In terms of the EU EEA, we estimate that 766,000 people were living with HIV by the end of 2022. So this issue of stigma is, of course, critical. UNAIDS target, as I said, says that less than 10% of people living with HIV and key populations should be experiencing stigma and discrimination. And why is this so important? Because our ability to achieve all other goals, whether it be on prevention, on testing, on treatment, on viral suppression, and even beyond viral suppression when it comes to quality of life, is so much dependent on addressing the issue of stigma. And stigma is an issue that we have been lacking data on for as long as I've been working in this field for 20 years, right? So we have sporadic data on stigma. So at ECDC, we tried to prioritize this a couple of years ago, trying to understand if we have a role to collect better data on stigma, both in the community, but also in the healthcare setting. And in 2021, we partnered with the European AIDS Treatment Group and AIDS Action Europe to develop a novel tool for how to measure stigma in the community. We ran that survey, and those results were during the Spanish presidency to the EU Council last year, and have really been used well. I think that data, very excited to be working with the community on that kind of data. We then, when that was ready, we then partnered with the European AIDS Clinical Society under the leadership of Esteban to see if we can develop a tool to try and measure stigma in the healthcare setting. And those are the results I'll be presenting today. But just to mention again, the community survey, it was published in September. I encourage you to read this report. And I just want to show 2 data points on this report because that helps set the context on what I'm going to be presenting. So this shows you the community experience of stigma in the healthcare setting. So on the left-hand side here, you see that in red and orange, 1/3 of the respondents reported that they were worried about being treated differently by healthcare staff. And as a consequence, 50% of those, roughly 18%, avoided healthcare services altogether because they were expected to be treated differently. So not only are people worried, but they actually avoid healthcare altogether. And if you belong to these risk groups, then that will actually impact your ability to go and get tested and link yourself to care for HIV, viral hepatitis, and other STIs. So this is the context, and this is what a lot of the report, the previous community report, was about. So this is why we moved on to EACTS and really tried to measure stigma in the healthcare setting. So we launched this survey in September last year, as I said, during our network meeting in Spain during the Spanish presidency. We developed this tool together with a group of experts, which I'll mention a bit later on. So we got absolutely great response rates from countries. We have data from 54 countries. Here you see the countries, the number of responses received and the sample per 100,000 population. And at the bottom right hand there, we see that we had over 18,000 respondents across the region, which is a phenomenal result, and we were very pleased with that. And that's all thanks to the focal points in countries who helped translate the survey and promote the survey and encourage people to respond to the survey. So here are some demographic characteristics of the respondents. So on the left-hand side here, we see that roughly 3/4 of the responses were from female healthcare workers, 25% by male healthcare workers. On the right-hand side, in terms of the professional roles of the respondents, the majority, 44%, were doctors, followed by nurses, and then you see all the other kind of management, administration staff that responded to the survey. Here on the left-hand side, we see that the type of healthcare facility where the respondents worked, so 58% worked in hospitals, followed by other clinic and medical offices and primary care centers. And on the right-hand side, the departments where they worked. So 16% in infectious disease clinics, other inpatient care, primary care, et cetera, et cetera. So I think we have a broad representation of where people work. And that was something we weren't really sure if we were going to get, but that's something that we're very happy with. So on to some of the results. So in terms of training and knowledge, so 65% of respondents said they had received some form of training when it comes to patients' informed consent and private confidentiality. 62% said they had some form of infection control training. And at the bottom there, 1/4 of respondents said that they received some form of training as it related to HIV stigma and discrimination. In terms of knowledge, so internationally and historically, there's not been a lot of studies on HIV knowledge, but we have UNAIDS and other scientific publications which measure knowledge, and typically this is how they measure knowledge. They provide correct statements about certain things, and they ask people, depending on what the topic is, if they agree or disagree to these kind of correct statements, right? Previous studies have not really looked into these 3 topics of U equals U, PEP, and PrEP, because they were relatively new concepts, and the studies that have existed before were really before these concepts. But what we did, we had 3 correct statements of what U equals U is, what PEP is, and what PrEP is. Ask respondents to agree, disagree, or say that they did not know if these were correct or not correct statements. And here are some of the results. So 39% of respondents disagreed or didn't know what the correct statement was around U equals U. So a significant proportion, 4 out of 10, did not know what the correct statement or didn't agree what the correct statement was on U equals U. That increased to 44% when it comes to post-exposure prophylaxis and 59% when it comes to PrEP. So 60% of respondents disagreed with these correct statements of what PrEP was. So quite high numbers. So here in green, you see that 31% of respondents answered correctly to all 3 correct statements, 21% to 2 out of 3 correct statements, 23% had correct on 1 of the 3 statements, and 1/4 of respondents responded incorrectly to all 3 statements. So on the right-hand side, 52% had medium to high knowledge of HIV prevention, and on the left-hand side, 48% had low or no knowledge on these questions. So looking at these knowledge questions now on prevention nutrition by healthcare profession, we see that doctors on the left-hand side here, doctors had higher level of knowledge compared to other groups that are listed here on the bottom. What's common for all these healthcare professions is that the knowledge on U equals U seemed to be higher compared to PEP, and PrEP was clearly the lowest level of agreement to these statements in terms of knowledge. So that's common for all these professions. In terms of knowledge by health facility, we see that people working in community centers had higher knowledge compared to those in hospitals, other clinics, dental clinics, and primary care. And again, the same kind of trends where knowledge on U equals U seemed to be higher than that of PEP and pre-exposure prophylaxis. This shows you knowledge of prevention and transmission by number of people living with HIV that you have cared for in the past year. And not surprisingly, if you've if you don't know if you've cared for anyone, if you haven't cared for anyone living with HIV, your knowledge on these three concepts is much lower than if you look on the right-hand side. If you've cared for many people living with HIV, your knowledge on these concepts are going to be much higher. But this is a quite nice linear graph, I think, that shows you that it's directly related to the number of people that you have cared for living with HIV. This shows you knowledge of prevention and transmission by geographical area in the WHO European region. So knowledge seems to be higher in the western parts of the region, quite similar for the center and east. Also, HIV attitudes and behaviors. Here we look at the level of worry when providing care to people living with HIV. So we see here that roughly 53% of respondents expressed some worry when dressing wounds of people living with HIV. And when it comes to drawing blood, 56% expressed some kind of worry on drawing blood for a person living with HIV. When you look at this worry by professional roles, students seem to be more worried compared to nurses, doctors, dental professionals, and allied health professionals. When you look at these worry by level of HIV knowledge here, so those with no knowledge on the left-hand side who answered wrong to all questions on knowledge had higher levels of worry, not surprisingly, compared to those with high levels of knowledge on the right-hand side. So the higher your knowledge, the lower level of worry for when providing care. So looking at worry by geographical location, and this is going to be similar trends throughout, where lower levels of worry in the western parts of the region, similar in the center and the east. 50% roughly expressed worry in those regions for both drawing blood and dressing wounds. Now looking at excessive measures when providing care to people living with HIV. Here we are looking specifically at avoiding physical contact and wearing double gloves when providing care or services for a person living with HIV. So here we see that 8% of respondents said they would avoid physical contact with a person living with HIV, and 26%, a quarter of respondents, said they would wear double gloves when providing care or services for a person living with HIV. Now, when we look at these excessive measures by professional role, we see on the left-hand side, for all categories, actually, wearing double gloves, as I said before, is much more common excessive measure compared to avoiding physical contact. And we see here that dental professionals at a much larger extent would wear double gloves compared to nurses, doctors, and other allied health professionals. This shows you the excessive measures by level of HIV knowledge again. So if you have lower knowledge, you're going to be more likely to use these excessive measures, both in terms of wearing gloves and avoiding physical contact. So on the right-hand side, if you have high knowledge, if you know all these concepts of prevention, and then your excessive measures would be much lower. This shows you, again, the excessive measures by a geographical region, lower in the west compared to that of the center and east. And wearing double gloves is much more common. Now, looking at the preference and reasons not to provide care to key populations affected by HIV. So here we had statements, and the statement here reads, "I prefer not to provide care or services," and then we list, I think the microphone is on for someone, but so the statement here is, "I prefer not to provide care or services to transgender men and women, sex workers, men who have sex with men, or people who inject prohibited drugs. So we see here that 6% of respondents preferred not to provide care or services to transgender men and women, sex workers, and men who have sex with men. And that doubled that percentage to 12% when it comes to people who inject drugs. So that seems to be a population particularly affected by this statement of not preferring to provide care or services. Now, if we look at this proportion of healthcare workers preferring not to provide care by geographical region, again, lower in the West, higher in the center, and especially in the East. Now, we ask the reasons for preferring not to provide care or services to certain populations. As you see on the left-hand side, roughly between 45 and 50% of respondents said they have not received training to work with these specific groups. Between 40 and 50% had not thought that these groups engaged in immoral behavior, and between 28 to 27 to 43% thought that they put them at higher risk for disease. Now, this left-hand side, where roughly 45 to 50% said they have not received training, that's actually something we can do something about. So if we put efforts into the training part, hopefully we can address these other misconceptions around immoral behavior and increased risk. So that's something that is a conclusion of this study. So this looks at healthcare workers reporting stigmatizing attitudes towards people living with HIV. So here, 12% agreed or strongly agreed with the statement that most people living with HIV have had too many sexual partners. 22%, so 1 in 5, agreed or strongly agreed with the statement that people acquire HIV because they engage in irresponsible behavior. And roughly 1/4, 26%, agreed or strongly agreed with the statement that people living with HIV with detectable viral loads should not be participating in sexual activity. Now, looking at observed stigma and discrimination in health facilities. Here we have healthcare workers who have observed different forms of stigma and discrimination towards people living with HIV in the workplace during the past 12 months. And we see these different forms of stigma at the bottom. So 22% had observed unwillingness to care for a person living with HIV. Similar percentage, 1 in 5, had observed disclosure of somebody's HIV status without consent. And 18% had observed poor quality of care for a person living with HIV in the past 12 months. In terms of discriminatory remarks, well, 30% said they had observed discriminatory remarks about the person living with HIV in the workplace in the past 12 months, so quite high percentages. If we look at this observed stigma and discrimination towards people living with HIV in the workplace by geographical region, not as huge differences as previously, so relatively high in West, Central, and East in terms of observed stigma. And to conclude here, so we have the evidence, as I've shown you before, that people living with HIV are worried about being treated differently in the healthcare setting, and as a result, actually avoid healthcare services altogether. That's the study we did previously with the community. These findings highlight existing gaps in HIV-related knowledge among healthcare workers, with roughly half of the respondents having low or no knowledge about key concepts of HIV transmission and prevention. Lower HIV-related knowledge is associated with higher levels of worry when providing care to people living with HIV and to higher use of excessive precaution infection measures. A notable proportion of healthcare workers preferred not to provide care or services to key populations at higher risk, especially for people who inject drugs. A significant proportion of healthcare workers had also observed different forms of stigma and discrimination towards people living with HIV in the workplace in the last 12 months. So this survey, I think, underscores the importance to implement targeted interventions aimed at different healthcare facilities and healthcare professionals, because there are differences here that we need to dig into to combat HIV-related stigma and discrimination in the healthcare setting. And that's the next steps that we will discuss with the ECDC on how to proceed with these kind of interventions. So I need to acknowledge a lot of people here. The first one I want to acknowledge is Ana Mendes Lopez, who is on the chat. So if you have the opportunity to wave her with these buttons, please do so. She's done an amazing job to lead us through this work over the past year. So she deserves a lot of the credit for this. The steering group led by Esteban Martinez, Anne Sullivan, Sanjay, Fiona, Catherine Darling, Daniel, Alex, Sini, Julia, and Joelle being critical in developing the instrument and then promoting the surveys, and all the partners in countries who actually did a lot of the work in translating the surveys, promoting the surveys, and getting a great sample size, and they need a lot of the credit. And of course, all the healthcare workers who took time to respond to the survey. A deal of gratitude. So I will stop there and then over back to you.
Thanks a lot, Timo. Thanks for sharing these very impressive results. And I agree, it's good to finally have some data out there that we can measure up against. So thanks to ECDC and EACS for taking the leadership in providing this, and also quite an impressive response rate. So it is solid results that you're presenting. Thank you. So we will take the discussion afterwards and hope to see some questions coming in the Q&A section. So please put questions there, and then I'll give the word to Esteban Martinez, President of EACS.
Thanks, Dorothy, and thank you, Taimur, for this overall and very extensive work done in the past few months, thanks to so many people, and particularly those you have mentioned. So I am a clinician. I have also the current role of president at EACS. We are proud of having collaborated with ECDC and along with many healthcare professionals across the European WHO region. So I will show some points I would like to emphasize next. So HIV stigma is a major barrier to HIV testing, and this is not only from the beginning, from testing and the possibility of knowing whether a given person may have or not HIV, but also to a continuum of care, and certainly it may affect every step in the continuum of prevention and care. So stigma is easily recognizable obstacle, though may be difficult to manage, and this is the reason why the survey was undertaken. Next. So we knew previously to the survey that there were different ways of showing the possibility of a stigma. Here you have some of them in a setting that is from the United States, Southern United States, but the way stigma may have within the healthcare setting may have different views and different points. Next. And we also know, and this has been clearly reflected in the survey, that those healthcare professionals with a higher level of knowledge about HIV may have a lower expected stigma, and those without so much knowledge may reflect the highest level of stigma. So certainly this brings us to a point in which knowledge about HIV prevention and care is important to decrease or to prevent the stigma. Next. Also, we know that healthcare professionals may be devoted to different fields in medicine, and for sure, not everybody knows perfectly or is updated with the latest knowledge in HIV. But although that may be true, what it is common to all healthcare people working in this field is that we should have always respect and compassion for the patient, for the person who is in front of us. Next. And also, very importantly, the language matters, not only what it is said, but how it is said. And this is about HIV, but in many other fields, in medicine and obviously in life, language may be a bridge, maybe positive, but maybe also negative, maybe something we have to take care of. And this is very important regarding HIV. Next. So addressing the stigma in the healthcare setting would probably improve the possibility of HIV testing, which is what are we discussing during this week, but also linking those people diagnosed with HIV to care after having the diagnosis, and also for those people without HIV but at risk of HIV, adhere to PrEP and other types of care, and getting other kinds of healthcare that they may need at the highest quality. Next. So you have seen that we cannot work alone, and we are very grateful to ECDC and to other partners to be engaged in this common objective of fighting against stigma and discrimination through different surveys that have been undertaken. Next. This is the one you have already seen, and certainly it will provide us with data that needs to be discussed, analyzed, and from such a wealth of data to try to retrieve the possible solutions to improve this kind of stigma and discrimination in people with HIV. Next. Okay, so with that, I finish here, and I am open to comments, to general discussion.
Great. Thank you very much, Esteban, for these perspectives. So we'll open up for questions and comments. So please use the question and answer box. So that there is one question posed around. So how do we what are the possible solutions to this? For me, of course, it's also looking at how do we address stigma in healthcare settings to ensure better offer and uptake of testing. But there's also a question in the chat looking at who would be best placed to develop interventions to improve the situation. So if I can turn over to you, Timo and Esteban, for some reflections on this.
Yeah, I think I can start this, but I think this is really for you as a clinician to tackle. But what I want to mention is that all the data we got, as you saw, great data from a lot of countries, all that data before we started our own analysis was sent to all national focal points now who sit on this data. And we've already seen several examples now from Italy, from Portugal, from other countries where they're actually analyzing this data to see what are the results from my specific country. And we're hoping that we see a lot of people taking different steps to address these findings. So it's not only incumbent on EACs, but it's incumbent for all people at national level who took part in the survey, who coordinated the survey, to share this survey results with national focal points, prevention people, program officers, everyone working with these topics in healthcare settings or otherwise in the ministries to develop information campaigns, trainings, etc. But Esteban, you would probably be much better placed to respond to this question on the next steps. Yeah. And just to say also that we will be discussing this as soon as these are published, and it's hopefully, I didn't say that, but in the next couple of weeks they will be published, that we will sit in the steering group now to talk a little bit about the next steps, what we can do about it. But over to you, Esteban.
Yeah, absolutely. I fully agree with you, Timur. I think the data are extensive. They reflect issues across all geographical regions in Europe. So this is a generalized issue, and it is updated. So the references from the past, unfortunately, are still live. And this data, knowing it and discussing it at different levels, maybe the whole European level, but also in every country, as in some countries the data allows for individual discussion, will not only get to the point of the problems, but also raise the voice on how we can manage stigma in a way that it is not theoretical. And certainly, to me, I think there are different ways of stigma to manifest, to become apparent. And there are two major barriers behind. One is the lack of knowledge. And the lack of knowledge is something regarding medicine or regarding health sciences. And certainly some people, even doctors, may have stopped in the past, maybe years ago when HIV was not so well known. And this has to be updated. For some other people who are administrative clerks or some others, the knowledge about medicine, although they may be in front of patients, may be lower, and certainly they have to have this kind of knowledge. And the other obstacle, besides knowledge, is attitude. And attitude is different from knowledge, and attitude reflects both a personal disposal in front of the people you have to take care of. We, as doctors, other healthcare professionals, are devoted to the people we are trying to care, although we have not enough knowledge to care for them. And also, there is a kind of societal attitude, and this may be also together with the social norms, the way that your hospital, your institution, your family, your school may be dealing with some problems. And this is a more deeper problem, and certainly the solutions would have to be more complex and probably adapted to every individual setting.
Thank you both. So you're mentioning training to increase knowledge as definitely something that needs to be increased. There's a question in the chat that goes a bit further than that. How do you think an intervention could look like? What would be an approach to intervene to reduce stigma in healthcare settings? And should interventions be implemented in HIV specialized healthcare or primary care or other?
Well, Espan, do you want to start with that one?
Yeah, whatever you want, Timur. I would say that obviously talking about it as a normal issue would make things easier everywhere, because you are not dealing with something hidden or forbidden or difficult to manage. It's a natural thing that anybody should be able to deal with, to talk about, etc. So that's the first step. And the second would be, at least for anyone involved in healthcare, to have knowledge not only on HIV, but on other conditions, other issues in which stigma may be evident, to try to avoid it from the perspective of knowledge. And the last one would be society, and for that is education with the new generations of children, etc., that should be emphasized.
And just to add on that, I think it's worth mentioning, so we are also working with EACS, ECDC is working with EACS and many partners, including you, Dorte, and your team at CHIP, on this issue of standards of care, right? And we are working on prioritizing certain standards now on treatment, on PrEP, on testing. And obviously, with these results, I think there's an opportunity to now develop certain standards around stigma in the healthcare setting with quality statements, and try and bring this down to clinic level to develop simple tools to try and measure the level of training, the level of knowledge, the level of stigma occurring with very simple tools can be done and audited at clinical level. And I think with those clinic level results, I think it would bring the opportunity to provide training and address a lot of these interventions at that level is much, much easier than I think, and at this larger European level that we're working at. And I think if we can develop tools and standards and auditable indicators at that level, I think that's a huge opportunity that I think we should try and leverage in the years ahead, probably next year already. So that's a suggestion that I think we will take forward.
So can you speak a little to now you made these two surveys and one in community, one in healthcare. What's the follow-up to the survey? You talked about discussing the results in the group, but is there any plans on repeating the survey or looking at measuring interventions? Or can you speak a little to that maybe?
Yeah, so I can start here. So I think when we envisaged this at the very beginning, 2-3 years ago, both surveys, we wanted to prioritize the community survey, move on to the healthcare one. And I do think the intention has always been to try and repeat this. It is time consuming. It's not very costly, to be honest. We have to mention that there are stigma indexes that are done at national level by community organizations, which are amazing. They are quite costly. They take a lot of resources, and that's why we've been lacking data, routine data from many other countries. So that's why we initiated this project. So it's not to replace those indices that are taking place. Those are critically important. But what this does is at a affordable price to try and measure something that is comparable across countries. So I think what I would like to do is analyze these results now, see how we can get some interventions in place or try to do something about these results, and hopefully measure them at least one more time before 2030 or around 2028, 2029 to see if there's any progress over time. So basically using the exact same instrument without changing them unless some fantastic new intervention comes in place that we need to measure, but to see if there's any movement over time. I think that's going to be critical. Now, this was a one-off. We have an understanding at one point in time, and I think we just need to repeat it at least once to see if there's progress over time. So that's hopefully the plan, if people agree with that and can commit to doing that.
Yeah, certainly, although the survey is aimed to try to find the issues that may be involved in stigma in the particular healthcare setting, we can derive from the results the potential solutions, and those solutions may be outlined in a general sense, but certainly they have to be fixed and framed according to the setting in which they have to be implemented. So for some, it may be the national setting. For some others, it may be the hospital or the outpatient, or maybe the dentist, or maybe the nurses, or maybe the administrative clerk, etc. So we can provide with potential suggestions derived from the results, but they will be have to be put into the frame by everyone else into the specific settings that they are dealing with.
Mm-hmm. Dorte, if I may, I see a question here about considering the high level of education among healthcare workers. Why do we think that stigma still exists in this group, and what do we think about that? And I think it's complex. For me, I think one slide that I did show the clear association between, if you meet people living with HIV on a frequent basis, your level of precautionary measures, your level of stigma, your level of fear reduces. So a lot of people that we do ask may not have that exposure, and I thought the data was quite clear on that. And I think that's the same with everything, right? So everything in society, if you're not aware of it, if it's foreign to you, you tend to have more stigma or fear or less knowledge about the topic. So it's related to knowledge, of course. So the less knowledge you have, the less opportunity there is for misunderstanding or conceptions around that. So I think that's what our results show, and that's why education becomes such an important. And also, 50% of respondents said, that why do you think you have these misconceptions? And it was because I'm not trained in this issue. And I think that was a frank response, and that tells us that, well, maybe that is what we need to do, focus on education. It sounds easy, it's going to be very difficult, but I think through different tools we can try and address that issue.
And that also goes for how you show that the level of stigma in community-based care centers is lower, right? That probably the knowledge here is higher.
And also in HIV clinics, certainly we all, even the administrative personnel, are more used to deal with any person, and certainly at the very end, we are all persons. And those kind of prejudices, which are the basis for stigma, disappear or are very, very small. Certainly are those specialities in which the relationship with people at risk or with HIV may be lower, who may still have knowledge from the 90s or 20 years ago, when the knowledge was in general much lower and inaccurate than today.
And so maybe a final comment from the chat, which is going back to what Testing Week has tried to promote for many years, namely integrated testing and increasing the focus on testing not for one disease but for several diseases when that makes sense. And a new report coming out also showing STI-related stigma. And I know you have also been conducting a survey looking at hepatitis. So can you give some thoughts on how to look at this in combination over the coming years? Yeah.
Yeah, I think it's a great question. We are moving towards more integrated care. This survey, potentially in retrospect, I'm not sure if that was what's meant with this question, could have addressed multiple issues at once, not only focusing on HIV, but also STIs and hepatitis and other aspects. And we have clearly influenced colleagues at EASL and at ECDC to look at this in terms of hepatitis. I think in the future we can look at doing an integrated approach as well to measuring stigma, right? It's not only specifically disease specific, it's on many different aspects. And I think that is a great suggestion that we should consider going forward. And because, yeah, I think if you have these stigma on one condition, it's probably going to be quite high on other conditions as well, even though we have, the evidence to show that stigma is very high, especially around HIV and hepatitis, I would say, but many other conditions, of course, very high levels of stigma. So yes, I think it's a great suggestion and something we can discuss forward. I guess the interventions would be quite similar, right? So if it's in a healthcare setting, you would have to tackle these interventions. It makes a lot of sense to do that. So yeah.
Great. Any final remarks from the two of you?
I have, if you allow me, Dorte, I have also seen why the interest in healthcare. I think healthcare is a cross of ways for delivery of clinical attention, for delivery of prevention, and certainly it is something which is central to the possibility of experiencing or having a stigma. But there are other settings in which stigma may appear, and certainly the knowledge in healthcare will also be potentially of benefit in other settings, school, maybe some specific settings, etc., etc.
Yeah, and just to say, so I think the community survey also indicated clearly that we asked questions around family and friends and private life, but also about healthcare settings. And it was the healthcare settings where the most experience around stigma in the healthcare setting was among people living with HIV. So that is really something we wanted to prioritize. And all people living with HIV should have access, should have close contact with the healthcare setting. And as we saw, there is avoidance of healthcare settings, so that was a priority. But I agree with the person who asked the question that, of course, we could address other areas as well. Over.
Great. Thank you so much. And we look forward, Timo and Esteban, to see the report being published. You can find the theme statement on the Testing Week website, and it also contains some links to materials that can be used in healthcare settings to make more awareness. Thanks so much, Timo, Esteban, and thank you everyone for attending, and enjoy the rest of Testing Week.